When it comes to being a new parent, nothing is worse than feeling helpless when your child is suffering. Fussiness, trouble feeding, not meeting their growth milestones. Why are these babies failing to thrive? These signs may be indicative of a larger problem that's responsible for stunting their growth at such an early age. Congenital heart defects, or CHDs, affect almost 1% of newborns every year. Of these children, 1 in 4 will be born with a critical CHD and will require a major surgical procedure within their first year of life. There are several congenital heart defects. These include ventricular septal defects, atrioventricular septal defects, and hypoplastic left heart syndrome. While these defects may share commonalities, no two child's defects are alike. Defects like these can cause improper blood flow through the heart, resulting in lungs being overworked from increased volumetric flow. To address this issue, physicians turn towards constricting pulmonary blood flow to reduce outflow to the child's lungs. This is done early in the child's development to mitigate overcirculation and preserve lung function, as it is critical to protect the child's pulmonary vasculature. The current go-to therapy is a pulmonary artery band, also known as a PA band. This procedure involves opening the child's chest and tying a Teflon strip around their pulmonary artery. Done within the first few weeks of life, it is used to maintain the integrity of their heart and lungs to prevent irreversible damage. This invasive surgery is only the first of many procedures this poor child will have to undergo within their first few months of life. Several key limitations and documented problems associated with the current PA band approach. PA bands can shift down the pulmonary branches and induce PA branch stenosis. In some cases, the band may erode in the pulmonary artery, or even worse, cause irreversible changes, leading to the development of pulmonary hypertension. Despite this host of complications, PA bands are still done as a stepping stone to allow the child time to grow in order to receive future corrective surgery. Considering the cost of pediatric cardiac procedures and the number of patients with CHDs requiring corrective surgery, our total addressable market is $300 million. With such a large market size, coupled with the severity of these complications, we figured there must be a better solution. After observing procedures in the cath lab of infants who had PA band migration, we discovered that as the patient grows, the band needs surgical readjustment, putting them at high risk. This led us to our first need statement. Physicians need a PA band that does not migrate to minimize adjustment surgeries, which increases time until definitive repair. Upon consultation with members of the pediatric cath team, it became evident that patients had to undergo too many surgeries due to PA banding complications. Minimizing surgeries would greatly improve their development and quality of life, leading us to our second need. Physicians need a non-surgical method for restricting flow within the pulmonary artery, thereby improving patient quality of life. In discussions with members of the pediatric cardiac care team, a repeated theme was to remove the usage of PA bands completely, uncovering our last need. Physicians need a reproducible method to mitigate pulmonary overcirculation by creating pulmonary vascular resistance to a measurement that is 1/3 of the systemic vascular resistance. We would like to thank the entire Duke pediatric care team, including the cath lab, sonographers, nurses, and CT surgeons for their contributions and insights during our needs finding process. We appreciate you all allowing us to observe your work, and we look forward to collaborating again next semester. Thank you.